All right, Chapter 10. Again, the disclosure statement. I don't own this material under fair use. I'm providing lecture content for my nursing students using this material. All content within is only for educational purposes for nursing students and does not provide medical advice. So this chapter, we're looking at school age kids. So the growth and development, the age-specific physical assessments that should be done, the medication approaches for those kind of kids, explain variations in nursing procedures for school-age children, strategies to promote health, emergency care, and strategies to support school-aged adolescents. Integrate chronic care concepts and age-specific competencies, complementary and alternative therapies used by school-age patients, and recognizing child abuse considerations relevant to those patients. Okay, so school age, what are we considering? So kindergarten was back there in the last one, so now we're going first grade, 12 years old. What is that? Fifth grade? Fifth, sixth grade? So the rest of elementary into middle school. So here we go. 6 to 12 years old. Their growing has considerably slowed, but they're still accomplishing major developmental tasks. So a variety of both physical and behavioral changes are happening, and they're similar to the late stage preschooler, whereas older school-age children are more similar to the adolescent. So be very careful when you're looking at test questions with this age group. Don't just assume it's a 6-year-old, okay? Careful assessment and adaptation on the part of the nurse will be required while taking care of patients in this age group. Okay, so the growth and development. The growth and development in this age group includes evaluating age-appropriate vaccinations and a generalized assessment of the school-age child. So remember back to kindergarten, first grade, second grade, third grade, what they were doing. You would go once a year down to the nurse's office and you would get height, weight, ears, hearing, vision, and scoliosis checks. So what they would do, typically, if you had a pool at your school, the pool is the perfect place to do this because everybody's in swim trunks and swimsuit and their back is readily accessible to you. So what they end up doing is going one day to gym class. All the school nurses show up and they go down the line and make sure you don't have lordosis, scoliosis, kyphosis, right? So typically you're going to see nurses in this area taking care of patients in their home health, school age, school nurses, and then pediatric nurses. So school age, you need to know about common illnesses, the milestones, and the medications that are usually prescribed to these kids. Home health nurse does a generalized assessment, focused assessment on the needs of the child and the prescribed care, and helps with needs that the patient's having at home. Evaluation of developmental milestones and a home evaluation. A home evaluation would be home safety, living conditions, that there's food in the home and that it's well taken care of, environmental safety like sidewalks and places to play, and the presence of caregivers in the home. The acute care nurse would be doing a head-to-toe assessment. Could be a sports physical as well. You see a lot of things going on with sports at this age as well. So a lot of them will be having height, weight, evaluation of fluid intake, pain assessment, and developmental milestones to tell them that they're okay to go play soccer or whatever they're doing. So you need to know the vital sign normal table in your book. The pulse ox We now add a pulse ox to most kids. A fever is now typically 101.4 or higher, and fevers don't usually cause seizures, although a sudden increase could. Kids that develop high fevers are usually a viral infection, and brain damage doesn't usually occur unless the fever is over 107.6. An untreated fever in a child will rarely go above 105. So, not an emergency thing like the younger kids. And they're gaining 3 kilograms a year in weight and 5 centimeters a year in height. So, just consider this age group adding 3 kilograms. Experiencing a growth spurt between 10 and 12 for girls and around 12 for boys. The fluid requirements, again, for these guys, you would fluid resuscitate with 1,000 and then 50 mils per kilogram over 10 kilograms. If they're over 20 kilograms, you would be doing 1,500 bolus and then adding 20 mils for each kilogram above 20 kilograms. So that's your mils per kg per day. So that's how we do fluid requirements in children. We'll do 1,000 and then add 50 for each kilogram above 10, up to 20 kilograms. After 20 kilograms, we just do a solid 1,500, 1.5 liters, and then add 20 for each kilogram over 20. You need to know that because they will test you on that. Occasionally on the NCLEX, they will do a fluid resuscitation. And then your vital signs are in your book as well. And then expected urine output. So the younger kids, it's 1.5 to 2 milliliters per kilogram per hour. And when you get to the older kids, it's 1 mil per kg per hour. So similar to adolescent into the adulthood area, it's 1 milliliter per hour per kilogram. We still use the FACES scale. We also use the visual analog or a numeric scale 1 to 10. As kids grow older, their vocabulary comes much higher, so you can do a much easier facial recognition scale or numbers with them. So, pain, usually most signs of pain, you're looking for child abuse versus bruises. Are there various stages of healing? Are there bruises on unusual body parts? Is there cigarette burns? That's a sign of a child abuse versus like dryness, rashes, eczema, abrasions, contusions, and scratches. So what I like to do is ask myself, is it plausible? Is it plausible that this happened? If they're telling me they were riding a bike at 2, yeah, I don't think so. If I know there's 3 wheels by 3, they ain't riding no bike at 2, okay? But when you get into the school age, that's kind of hard because that is plausible, okay? So think about when we do have physical behavior, physical abuse on a child, then we need to definitely go ahead and turn that parent in and do a mandated reporter. So they should understand the difference between good touch, bad touch, and the danger with engaging strangers. Stranger danger usually happens at kindergarten, first grade. And they are taught that this is a good time to say something while they're at school. So after school time should be supervised and structured. You don't want them out on the playground or something and getting hurt when you don't have a school nurse on board. Okay, so when you're doing head to toe assessment, you're looking for lice because kids are very susceptible to lice. Hair dryness, brittleness, which could indicate the nutrition status to you. Open lesions, signs of trauma, headaches, difficulty concentrating, loss of consciousness. Eyes, you're doing equal and reactive to light, your perla. The use of glasses or contacts, visual acuity, broken blood vessels, jaundice or dryness. In the ears, you're assessing for a hearing aid, cochlear implant, any hearing acuity, wax buildup that can impair hearing, and excessive buildup of fluid in the canals. So if somebody comes to you and they're pulling down on their ear, it's usually an ear infection. Go ahead, look in, see if that is a problem. Kids with cochlear implants or hearing aids, there's usually no problem with these kids versus kids with normal hearing. With the aids, they are definitely right up there with their children of their age. But overall, the quality of life and the opportunity to intervene early for these kids is so important. Like I said, they can be fitted with hearing aids at 5 days of life. You want them to be fitted with hearing aids prior to hearing sound. And then teeth. So the big thing in this age group that we're looking for is baby teeth are going away and eruption of new adult teeth happen at 6 years old. So they love to ask you about an emergency with a tooth falling out. What do you do? Okay, so we all know our old moms used to say, put it in a glass of milk. Okay, that is not going to be the answer. So as soon as somebody's tooth falls out, you want to go ahead and clean it quickly and put it back in the socket. Okay, so if it fell out in dirt, you would clean it with saline and then put it back in the socket. It has a better chance of being alive and being well when they get to the dentist. So remember that for the test question. They always love to trick you with the glass of milk theory. You will also start to see kids at the end of this stage getting braces, spacing of teeth. Overall, they go to the orthodontic for that, and that's pretty much self-limited. We don't really do much with that. We're just promoting dental hygiene and dental checkups every 6 months with fluoride treatment if we know that the fluoride in the water is low in their area. Kids are often increased risk for tooth decay, improper hygiene, and unusual growth patterns. So just be aware of loose teeth, orthodontic devices and stuff that need to be removed or observed during an emergency. Belief in the tooth fairy during this age. So the tooth fairy comes and rewards them with money. Don't assume the tooth fairy visits every home because this is influenced by culture. Throat, the trachea is midlined, any enlarged thyroid, difficulty swallowing, redness, lesions in the throat. Nose, looking for blue, boggy appearance of buccal membranes. Allergies. Allergies, you tend to see them going like this a lot and pushing up on their nose. So they'll usually end up with a ridge on the top of their nose. So you can look for that. Typically, you're just talking to the mom and just educating parents about saline, distilled, or other approved water over tap water because of the risk of infection when they're rinsing the sinuses. Saline nasal irrigation has been found to have a positive impact, but adoption is slow in the US. Nosebleeds, mucal dryness, airflow, cardiovascular, you're looking for any congenital history, auscultation, corrected cardiac defects. You could see a midline incision. The scars on the chest will tell you that. Heart murmurs in kids, typically 90% of them are just fine and they have a heart murmur, but often it's a result of that turbulent blood flow through the aorta or pulmonary artery. So your heart sounds should have a normal S1, S2. If you have another one, you can certainly ask if they've been seeing a doctor for their heart. Respiratory, usually the only history is asthma, but you can also think cystic fibrosis as well. You might have kids with cystic fibrosis. So that's asthma is the most prevalent chronic illness in kids. Some of them may be getting allergy shots, and you may be asked to give those during school hours. Lung sounds should be clear. If there is anything such as barrel chest, club fingers, that is signs and symptoms of a more chronic respiratory issue, those NICU kids could be a chronic lung and be on oxygen during school hours. Abnormalities, crackles, rhonchi, wheezes, retracting, grunting, flaring, call 911. Get that kid in because he's having much more problems than we need to be. Typically, if they come to the nurse's office, you're giving them an albuterol inhaler and they're good to go for the rest of the day. Assess any color issues, pallor, cyanosis. And typically, we're not dealing with nicotine at this age. And school use has gone down, especially because of the e-cigarettes. But remember that we're constantly doing that education. GI, enuresis, we should not have enuresis during the night. We should not be wetting the bed anymore. There shouldn't be urine incontinence. There could be deliberate withholding of stool. So that word you want to definitely know because they could. And typically, that's a control issue thing. Constipation, diarrhea, again, that's not usual for kids of this age. And if it is, then their parents have already taken care of that and they're on a regimen of prunes or whatever they need. Girls near the end of this stage are going to go into menses. So they're going to have a potentially scary time. So you might have early discussions. So the primary caregiver should prepare the person for this. But a lot of times that ends up on school nurses' plates. So what we do is typically take them aside at a gym class or take them aside one day and talk to them about pads, tampons, the first period, so that they're not freaked out by that. Tanner's stages, you've got to know that for the test. That'll be in chapter 11. We'll talk about that. Some kids might have precocious puberty, and that's puberty starting before the age of 7 and the age of 9 for boys. So that is appropriate social support for the kids that are affected because they're going to start seeing hair development and breast development that the other kids don't have. The onset of puberty in boys will be accompanied by increased body mass, thickness of hair on the genitalias and the body, nocturnal emissions, and normal part of puberty, but it can be late school age, more likely in adolescence. Neurovascular, neuromuscular, musculoskeletal, increased coordination, fine motor skills, balance. You can usually see this in gym class. Scoliosis checks at age 12. And then just know your Piaget, Freud, Erickson, and Kohlberg again. Piaget, mastery of mathematics and skills, serial numbers, cause and effect. And they usually see the perspective of other people now. So that's good. They can see the reaction to the teacher when they're misbehaving. So in Freud, this is the latency stage. In Erickson, this is industry versus inferiority. So just remember, kids are industrious. They're trying to learn new things. They're getting new tasks, new sports and things like that. So this is an easy one to remember. And then socially, they love to form clubs with rules. Remember the clubhouse. Favorite activities with the best friend, socialize primarily with children of the same gender. And that's when you know that it's happening when they start talking to the boys, because the boys have cooties and the girls are ugly. Following rules, understanding consequences, playing games, and they might have a collection of something. like baseball cards or whatever. Okay. So in this age group, we're also looking for dyslexia. Dyslexia might come out as well when they're having trouble keeping up with the rest of the class. Dyslexia typically is challenges in reading, writing, and comprehending written material. If they don't receive academic support, they could have trouble with friends, peer relations, and extracurricular activities. They might have future issues with homelessness, suicide, depression, substance abuse, and juvenile delinquency. So the earlier we can identify them and help them, the better. Okay, let's see. Here's a test question. So blue or boggy appearance of nasal mucosa. What did I say that was? Blue or boggy nasal mucosa was allergies. And that nose, that little ridge on their nose. Okay, so most of the time in medication administration, these guys are going to be just fine. You hand it to them, they take it, and maybe a chaser of an ice pop or pinch their nose while ingesting the material, right? So these kids should be going from a liquid to a tablet. These days, you can't assume that, so ask them if they prefer to take it orally or by pill. But most times, kids will go ahead and be able to take medications very easily at this age. Subcutaneous meds, EMLA cream being the biggest one. EMLA cream is lidocaine in a solution, but it takes a half hour to actually work. So if you were going to put in an IV, you would do that first. Any superficial surgery on the skin, anything like that, you would go ahead and do that. Sub-Q, just consider if they're on insulin, they know how to do that. They should be able to get it to do that on the inside of this by themselves. IV medications, typically, why are they going to have IV medications, right? The kids that I can think of are like cystic fibrosis that's going in the hospital for a tune-up, as they call it. Okay. So otherwise, these guys are more intentional injuries, unintentional injuries. Trust is a big thing. Look, talk, touch approach. So look at this, talk about it, and then touch. Safety, nutrition, exercise. So the safety involved with unintentional injuries. Automobile collisions are the most common unintentional injury in school-age kids. A child age 7 should use a forward-facing car seat until they reach the height and weight provided by the manufacturer. Booster seats should be used to allow proper seatbelt placement. And then 8 to 12 should remain in the booster seat until they've reached a height of 4 foot 9 inches and the seatbelt fits properly. A new car seat may be purchased if the damaged car seat damaged in a crash. And just make sure that the children guardian knows how to put those in. Head injuries are going to happen when you're on bikes and around vehicles, right? So remember, bike safety is really important in this age group. Sometimes we'll do like a bike rodeo and they'll bring their bikes to school and we'll be able to check their equipment and make sure it's okay. Some old guy in the community that likes to fix bikes, you know, one of those things. We'll do a bike rodeo. They'll come in and we'll do safety day, and then we'll give out some free bike helmets if people don't have bike helmets. Remember, bike, scooter, skateboard, and sports safety. So we definitely want to make sure we don't have those mild concussions going on the field without helmets. And then being able to cross the street by themselves. especially if they're in line for the bus pickup, right? Needing direct supervision, typically if they can start playing alone by themselves. By the end of the phase, it'll be more unsupervised activities. Readiness to be left unsupervised will vary by developmental level. Older school-age children may start babysitting to get more independent and more exciting and dangerous activities. TikTok included. And then they start doing football, baseball, swimming, and cheerleading and things like that that are more team activities. How do you know if your kid is ready for babysitting? Do they know fire safety? Can they observe children of various younger ages, and do they know CPR, just in case, right? So a lot of places will have babysitting classes, hospitals, YMCA might have a babysitting class, and that's kind of fun because now they're making some money. Nutrition in this age, again, parents shape the feeding and mealtime practices for kids. So parental monitoring of food and amounts, decreasing skipped meals. Family meal times are so important. It's the one time a day that everybody can get together, but unfortunately, a lot of moms are working, especially nursing. So sometimes we miss out on those school conversations over lunch. Look at your BMI, your lipid levels, your insulin levels, your blood pressure. Increased risk of arteriosclerosis and obesity in adulthood. So overweight kids have a greatest chance of being overweight in adulthood. So now's the time to really model and direct communication over a healthy diet that will lead into adulthood. But if they're going home to parents that don't care about that and can't afford good nutrition, then you're on the losing battle of that. A lot of places will have the backpack programs so that we can support kids that don't have a meal. At least they'll have something to eat with the backpack system. Exercise, typically they're getting at least an hour of gym a week or two. So typically without sports even, they're going to gym class at least once or twice a week, and also having some kind of playground time. There could be ball, jump rope, bike riding, skating, and playground equipment use. School exercise programs like skip rope day. You skip rope all of the day to make money for some organization. Limiting screen time to 2 hours a day. Children should at least have 1 hour of physical activity a day. School, usually in this area, you're starting to see a little bit of school avoidance, refusal, and phobia. And that comes from bullying at school. They'll have a stomach ache only on school days. They refuse to attend school. There's probably some kind of something going on there. So having everybody involved, teachers, the school counselors, the parents, and the primary caregivers, and healthcare professionals all on the same page. Typically, the answer to the test question is not going to be give them a day off. It's going to be get them back in school. Their goal from 6 to 11, their goal is daily school is the best activity for them. Okay, so if they're in the hospital, we need to get their schoolwork so that they can keep up. Bullying comes into play, like I said, substance abuse, sexual activity at the end of this. Alcohol, drugs, tobacco, so we usually do a DARE program in schools. Caregivers start discussing sex. Right around the 6th grade is that health class that you start talking about that. And that's where we can have those discussions and they take home a bag of flour all day long. Remember that conversation? So you took home a bag of flour or a baby and you had to take care of it. And some of the babies would be set to a certain hour where they would just cry incessantly. Okay. So things like that we do with those age groups. Caregivers should certainly ask about sexting and online child activity. So if you see that going on, just be a person that they can trust, that they can talk to about that. Emergency care are typically going to be unintentional injuries and cancer. Could be two of the worst case scenarios in this age group. Unintentional injuries and cancer are the two leading causes of death in 5 to 9-year-olds. So unintentional injuries and suicide are two of the leading causes in 10 to 14. Suicide recently surpassing cancer in this age group. So a child has been injured. The family often sees the ER in the crisis. Broken arms, broken legs, all that good stuff. Acute care, they're in the hospital probably one night, if that, and gone home. So a lot of teaching. CAS, remember CAS, so you got to do that whole thing. So compartment syndrome, right? CMS checks, you're teaching the mom how to do that because the kid's going to be leaving the hospital very quickly. Early warning systems happen to exist in hospitals where as you put in your vital signs, it starts giving you warnings. And the warnings will tell you what's going wrong with your patient. So the PEWS, the MEWS are the two most common of those systems. The child life specialist comes into their role. If they're going to have surgery or something like that, then they will have a child life specialist come and help act out the planned procedure, which significantly decreases anxiety. Accompanying a school-age child to a procedure or test provides distraction and coaching and planning for celebrations if the child is in the hospital. Therapeutic puppetry, coordinating an activity room where the child can play. If they're in isolation, they'll have toys brought to their room, but all toys should be cleaned with water and disinfectant. So that's why most kids get toys in their room to keep in their room and leave there. Just consider any test question about children in a playroom being an isolation concern. Everything needs to be cleanable and put back away. So you see the PEWS score in your book. It's based on behavior, cardiovascular, and respiratory. So as you're charting your vitals, it's telling us when they're chronically ill that something is happening. So someone who's chronically ill, like cancer, we're really looking at home care situations. In home care, which is a great job. Oh my gosh. Great job. Ventilator dependent child, tracheostomy, an immunocompromised child that can't be around other children, NG tube feedings, gastric feedings, ostomy care, oxygen, IV antibiotic, TPN, urinary catheterizations, the full realm of care right at their bedside. So these kids obviously are not the ones that are going to school. They're truly sick and they're going to be at home or in the children's hospital most of their life. But we still need to go ahead and either do homeschooling or an individualized care needs to be made, a plan with the school to be able to keep this going. School for hospitalized children, I cannot stress this enough. You've got to get the schoolwork and you've got to keep them from falling behind. That is your job as a nurse in a pediatric hospital. Normalizing as much as possible when they do have that situation going on. Again, with child abuse, bringing this back up, think to yourself, is it plausible, right? So just keep that in mind. Is it plausible? If it's plausible, then we're okay. But if it's not plausible and it looks like child abuse, then we need to call that. Typically, you look at the child and if they could do that, and if they're mentally delayed or a NICU kid, they're probably more at risk, okay? Remember that? If they're a developmentally delayed child or a NICU kid, they're probably bigger at risk for something happening, okay? There's a lot of time in the NICU. Those kids are treated extra special. So think about that. If somebody's not, that really doesn't set well. Okay. EMLA cream. What is EMLA cream for? We said a local anesthetic. A local anesthetic, it's a mixture of different local anesthetics that work prior to a painful procedure. All right, so in this chapter, we've talked about growth and development, physical assessment, health promotion, emergency care, acute hospitalization, and chronically ill child care.